going to talk about optimizing the digital workflows in full arch edentulous implant rehabilitations. I'm a periodontist. I have a private practice called Dentist Studio in Byblos, Lebanon. I'm also instructor at the Craniofacial Research Laboratory and Digital Dentistry Department at the St. Joseph University of Beirut. I come from Batroun, a coastal town in Lebanon, known for its beautiful sea, water sports, and nearby mountains. These elements, which I love, are a big part of my life, and I do my best to pass on this passion for nature to my children. Since my childhood, I had also deep passion for technology, and during my residency, I discovered digital implantology, which was a perfect blend of my interest in technology and my dental career. However, with practice, I discovered that the guided surgery process is not that simple and requires a rather steep learning curve. The process depends on several factors that can alter it, and one of these factors is the edentation type. In my previous presentation, I talked about how to improve the full immediate extraction and implantation cases with high radiographic scatter with the use of the digital alignment devices. Today, I'm going to focus on the fully edentulous workflow in digital implantology. So, in fully edentulous patients, we generally have to prepare the patient for the dual scan protocol. And if the patient doesn't have a previous denture, we have to fabricate a new one. And that requires all those clinical and lab steps in order to do it. And finally, add those radio-opaque markers that will be used for the superimposition. And following this, we'll have to do 2 CBCT scans with the dual scan protocol. So the second CBCT objective is to create a 3D model of this prosthesis in order to use it as a prosthetic reference and as a support for the guide design inside the software. Now, however, with this technique, in addition to the fact that it requires several steps to do it, it can generate errors while doing the conversion from DICOM to 3D model and might be technique sensitive because it's also dependent on which gray value threshold we select during the segmentation process. And the values of deviation with root mean square can range from 450 microns to more than 1,000 microns. That's why, with the advent of intraoral scanners, several authors have recommended replacing the CBCT conversion of the denture by scanning it extraorally with an intraoral scanner. This approach allows us to skip a step for the second CBCT and increases the accuracy of this conversion to reach approximately 350 microns. While also some other authors stated that they reach around 130 microns accuracy with this technique compared to 397 microns using the CBCT conversion. So now, can we further improve these workflows in fully edentulous patients with the current digital techniques that we have? We will respond to this question with the following case. We have here a case of a fully edentulous patient with dentures supported by locators. The patient is a 73 years old male with no major health issues. He has 2 fractured upper implants and suffers from periodontal tissue loss around the lower implants. The patient stated that he already underwent several implant surgery and had many previous implant failures. While viewing the panoramic X-ray, we noticed the severely resorbed maxilla with the failed implants and also an advanced mimetization of the sinuses. For the lower arch, we noticed that we have limited posterior bone height above the nerve and bone defects around the placed implants. It was decided that we start with the removal of the failing implants in the upper jaw, put a temporary upper denture, and wait for the CBCT in order to take decision regarding the lower implants and do the appropriate treatment plan for both jaws. This is the first step of the removal of the upper failed implants. And after the initial healing, we wanted to proceed with the patient preparation for the CBCT scan. The patient had a pre-existing denture, but this denture had a poor tooth configuration, a collapsed vertical dimension of occlusion, and it was non-adapted to the mucosa. So in this case, we had to replace it with a new one in order to use it as a radiological guide. With the presence of intraoral scanners, we decided to simplify the process by scanning the old dentures with the Medit i700 scanner. This is the regular occlusion scan with the initial vertical dimension of the patient. And this is the new byte registration, where we opened a little bit the vertical dimension and registered a new byte scan, so with the corrected vertical dimension. Based on this acquired data, we have separated the intaglio surface of the prosthesis and fabricated a customized impression tray using a combination of the Medit design and the Blender for Dental software. And then we took regular impressions with those trays, because till now, intraoral scanners are still not efficient in taking the dynamic impression of the peripheral joint and or the soft palate. But in this case, we did not proceed with the traditional way. We scanned the impression that we took with the Medit i700 and inverted it in order to have the jaw models. Those models were aligned to the models from the new byte registration, and like this, we achieved a digital setup with the adjusted vertical dimensions. So this new setup will be used in order to do like the teeth setup for the new denture design. This video shows the design of the denture of the upper jaw. And this is the denture base that was printed. And to the right, the selected physical teeth from the library that were placed and cemented into their indentations in the base. This is the full finished digital denture. Now, in regular cases, depending on what we saw earlier, we will have to scan this denture and add radio-opaque markers to it in order to do the dual scan CBCT protocol. But here, in this case, we don't need to do that because we already have the digital model, so we can skip this part. And based on this digital design, we can modify it in a way to have a place for the radio-opaque markers to be inserted inside it. Like this, we will have two models. The first one is the printed alignment device, or the pad, the device that we will print physically. And the other one is the DAB, the digital alignment device that we will use inside the software for the superimposition because it already holds those markers. Now, depending on the literature, the models that are printed at 45 degrees in the 3D printing slicing software have the lowest manufacturing 3D deviation by comparing it to the initial design. And it is around 86 microns. Now, if we compare it to the previous numbers with the intraoral scanning, we see that this error from the manufacturing is lower than the error of scanning a denture with the intraoral scan. So, in summary, now we will explain the workflow with those different techniques. So, with the CBCT conversion, we have the more steps and more deviation error while digitizing the denture. With the iOS, we have fewer steps and fewer errors than the CBCT conversion. And with the digital alignment devices, it's the opposite way around. So we have the digital design, but we are fabricating the physical device that we will take the CBCT with it. And it seems that the accuracy is around 100 microns. So that seems for me the best option to go with. Those are the printed alignment devices in the pre-4 slicing software, and the alignment devices printed, and then we bonded the radio-opaque markers of flowable composite in their indentation sites. This is now a comparison between the digital and the physical version of the digital alignment devices. And now, with this technique, we only have to do one single CBCT scan because we already have the digital alignment device. So the DAD will be aligned to the CBCT using the radio-opaque markers. And later, so after we align this digital alignment device to the CBCT, all the ancillary models and floating models that are already aligned to this digital alignment device, like the jaw model and the bone segmentation, can be automatically aligned to it. So the next step now was the assessment of the previously placed implants. As we see, the implants placed inside 33 presents a bone defect, but its position is a little bit outside the bone envelope, making bone grafting in this region inadvisable. So it was decided to keep it, but to disinfect it and polish the buccal surface of the implant. But for the other implant, it had a contained defect where we could potentially gain some bone if we graft the site. The implant simulation was done in the R2Gate software based on the available bone and prosthetic reference, and it was decided to add 4 more implants and do an immediate loading on all implants except implant number 46 because it needed a GBR and it was also a short implant. So those are the cross sections of the implants to be placed and the corresponding digital eye report for each of them showing an adequate bone quality for immediate loading. In our treatment plan, we wanted to do this case-guided, but with a flap approach, because we wanted to treat our old implants, to do a GBR on the tooth on the implant number 46, and because we also had a proximity with the anatomical structure, so it would be safer to do it with a flap. So we decided to do a new guide design that can accommodate a flap without having to be bone supported in order to reduce the post-operative morbidity from extensive flap reflection. So this guide features 2 sections. One section that is highlighted in blue that will be in direct contact of the mucosa with the mucosa to easily position the guide, and this region is located outside our incision area. In red, we have another section with a 3 mm spacing from the mucosa and corresponds to the region where we have to open a flap. So if we take a section on part of this guide, it's a cross section, we see that on its periphery, it's touching the mucosa, but in the center, it has an offset, which will give room for the mucosa after we make the incision and flap reflection to accommodate this flap inside the guide and not outside it. And this will permit to do an open flap guide without extensive open. We will see now a video showing the surgical procedure. First, we start with the fixation guide, where we fix the pins, and then we switch to the drilling guide, and we pinpoint the locations of the osteotomies in order to make the extent of the incision based on the implant sites. And then we do the flap reflection. We can clean and disinfect the old implants. And then we place the guide again to do the final drilling and to place the implants in a fully guided way. We also designed an immediate fixed prosthesis for the implants, which comes with its own guide to position it correctly in the mouth with the desired position and vertical dimension. This is a copy of the previous denture design, but it's separated into 2 pieces, the PMMA part and the holder part. The PMMA and its holder are placed on top of the mucosa and the temporary cylinders placed inside the holes and relined using composite resin. Like this, the patient will leave our office with a new fixed implant-supported bridge, and this is the temporary restoration 2 weeks after healing. After 3 months of healing, the impressions were taken to fabricate the permanent fixed solutions. In this case, a thimble bridge was designed in a way to have a fixed metal bar, red ceramic, and on top of it, 3 sections of full monolithic zirconia bridges. The tie bases were cemented to the metal bar, and the zirconia crown cemented from the other side, while still having through access if we'd like to remove and place back the bridge later on. This is a panoramic image showing the bone condition 1 year after loading. I also prefer to take intraoral X-rays that shows us more precisely the state of the bone. And here we can see the stability of the bone on the new as well as on the old implants treated more than 2 years after load. We also have to note that the patient was happy with this upper denture and decided not to undergo an upper implant rehabilitation for the moment. And finally, in this case, we have seen many enhancements in the workflow of fully edentulous jaws, including a faster fabrication process of dentures and radiographic guides, the digital alignment devices simplifying the workflow and reducing the steps, an accurate 3D planning using the 3D segmentations and digital eye aiding in the decision-making, surgical guide design optimization to open a flap with less invasive surgery, and finally, we also demonstrated a simple yet efficient way for the immediate temporization technique. And thank you.